Interesting session tonight, and it's going to be a great opportunity to hear about the model that's being put into place and the pilot that's been put into place in our region, and to certainly ask some questions at the end of the session as well. So just a little bit of housekeeping. We're going to try and keep everyone on mute as much as possible with such a large number of people attending. It's just really important to keep the background noise down to make sure it's nice and clear for everyone. So do try and keep yourself on mute if you can. For questions, we thought it might be best if we utilise the chat function. So if you put your mouse on your screen, you'll have a little toolbar that normally runs across the bottom, and there's a speech bubble there. And within that, you can type your questions. Myself and we've got Madeline, who's our program support officer. She will be looking to keep an eye out on the questions and make sure they get asked. And as I said, we'll have a bunch of question time at the end. As well. Again, more people keep on coming through, which is great. At the end of the session, so we'll make sure that there's an evaluation that gets sent out. We're really keen to see your thoughts on tonight's session, and we're also looking at planning some additional education sessions in the coming weeks. At this stage, looking to hold them probably every fortnight on COVID and different related topics that are of most importance to the general practices in our community. So we're really keen to hear on what you think you might need more information on. We obviously will look to create sessions that are most relevant to you. So if you can take a moment to fill that in, that'd be really helpful for our planning of that, and we'll let you know as soon as possible the different topics we've got in that series coming up and when those sessions are going to be held, but probably will be in a similar format to this: bit of presentation, bit of question time, where we can all get everything covered in there. Just a quick reminder about, I know a lot of you are probably all up on everything that's happening with COVID, but these are just some of the main ways that we recommend to make your life that little bit easier, to make sure you're getting all the most up-to-date information. So we've put the 5 S's in there, so making sure you're checking the quick reference guides on the DHHS website. If you haven't already and you're not currently receiving the regular updates that come from the PHN, highly recommend that. That's information that's really condensed down to that's most relevant to the region and the most up-to-date information. They usually come out every couple of days, depending on how quickly the changes are happening. So highly recommend that. Let us know if you haven't received that or you're not and would like to. The Chief Health Officer alerts, obviously, we've got the hotline number there that's been running for a while. And just put the extra reminder in down the bottom, don't forget the health pathways. They're actually COVID-specific pages that have been set up and are constantly being updated to match the current guidelines of what's happening there. So COVID-19 health pathways, and feel free to reach out to us if you haven't really used health pathways before. If you don't have your automatic log on yet, we can certainly help get that set up for you. Now, I'm not going to take up too much more of your time, so I'll just take a moment to introduce the presenters we have today and the people that are going to form part of the panel to try and answer as many questions as possible tonight. So big thank you particularly to Dr. Nicole Allard from cohealth. So she's one of the great GPs there and has been a clinical lead for putting this model together. It's going to be one of the main presenters, along with Dr. Alistair Miller, who's from the Royal Melbourne Hospital. Respiratory and sleep physician is also, as I said, one of the clinical leads for this model tonight. So all things model related there. We'll be presenting that to us tonight. We've also got Bianca Bell, who's from the North West Melbourne PHN. She's actually the Director of the Primary Healthcare Improvement Division. So we'll be answering any questions that we have around how the PHN is supporting general practices at this time and going forward. And Michelle Tideman will be joining us from cohealth, if she hasn't already, for any particular questions around the REDCap side of things. So I reckon I'll hand it over to you, Nicole, if you're ready to go. I'll start sharing my screen and we'll get started.
Always remember to take yourself off mute before you start. I just need to share my screen. Sorry, Alison, can you just remind me how to do that? I seem to have different...
Yep, so have you got the toolbar in front of you?
Yep.
So it's next to the microphone.
Yep. Okay, yep. Sorry, I think I use so many different platforms at the moment, but it's, yes, anyway. Okay, so does that come up? Okay.
Yes. Yep.
Okay.
There we go. Yep.
All right. So everyone, I can't actually see the chat, so Alison's going to moderate the chat on the side for Alistair and myself and Bianca and or Michelle to go through. So My name's Nicole Allard. I'm a clinical co-lead along with Karen Linton, who's also on this call for cohealth with. And tonight we're just going to be looking specifically at caring for COVID positive patients in the community, which is a new pilot in partnership with the Royal Melbourne Hospital, cohealth, the PHN and the department. I also want to acknowledge country. This is the Yarra just nearish me, where I can walk, just in my 5 kilometre radius, I think. I want to acknowledge I'm on the land of the Wurundjeri people of the Kulin Nation and pay my respect to elders past, present and emerging. Neither Alistair and I have any conflicts of interest to declare for this evening's presentation. So I think I put up a photo of 33 Alfred Street, which is one of the tower blocks that was locked down for the longest period in Melbourne, because in some ways this is where this pilot began. It began very much with cohealth seeing a need for primary care services and Royal Melbourne also being very involved with hospital in the home and also testing in the towers. And through this process, it became really evident that there was a need for care for COVID positive people and their families and households in these difficult circumstances. So just a little bit of the big stats. I mean, it's really all about Victoria, as we all know, and a lot of it's in the northwest of Melbourne. So at the moment, we've got, you know, nearly 10,000 active cases in Australia, 658 admitted to hospital. This is yesterday, so there's probably another 19 or 20 or more, and 51 cases in intensive care. This is just from the national stats today, but it was from last night. But when we get more local, the problems are clearly bigger, and the local government areas where there are the highest number of cases are very much in the northwest Melbourne catchment and also down in Casey. And COVID is managing to really identify the social determinants of disease. It's following a classic thing. And there was a great article actually in The Age today about how casualisation of workforces means that there's a much higher percentage in all these LGAs, and this is partly how COVID has spread in these communities. Just you can get this off the Department of Health website. This is active cases, and this is kind of the top 10, and certainly most of those are actually in our northwest Melbourne PHN catchment. So just to think about COVID-19, so 85% of people can actually have mild disease and can be managed in the community. There's different estimates of how many people are asymptomatic with COVID, up to 40%. There are some higher estimates of that. And it's more likely that you're asymptomatic when you're young, and you're more likely to have milder disease when you're young. About 15% will require hospitalisation and 5% require intensive care, which really means ventilation. And you're much more likely to need hospital admission if you're an older age or you have significant comorbidities. And the important thing is now we do have a treatment for COVID. So dexamethasone actually reduces morbidity and mortality. So what about GPs and COVID? So obviously with the kind of numbers we've got in the community, any ability for a centralised response to provide care to people has been exceeded. So there needs to be a comprehensive response in primary care. And we have a workforce who are skilled in telehealth, who are ideally placed to monitor mild disease in the community. And to date, I think most GPs would agree that the emphasis has been on assessment of people who have COVID rather than how to manage mild disease in the community. And we strongly believe that GPs can strengthen the public health response and contribute across, you know, workplace testing, aged care and other settings, because GPs are the healthcare providers in a lot of these settings. So I'm sorry, this has come out slightly blurry. This is just the red flags from the health pathways. And this is the red flags for COVID disease. So this is if you've got someone with mild COVID disease, you're worried about new or increasing shortness of breath, chest pain or tightness, syncope, altered mental state, severe weakness, hemoptysis. And we've also consistently missing meals also. So these are the kind of the red flags that we talk about, and it's about identifying those in the community with those issues and trying to get them to hospital in a timely way so they don't turn up when they need to be intubated. They turn up in time to get oxygen and dexamethasone. So what's the public health response? So the public health unit of the Department of Health is responsible for contact tracing, testing of contacts, isolation compliance, and release for isolation. And previously, like more than a month ago, when there was not as many cases as we have now, they were also taking responsibility for medical follow-up, but it was predominantly by text message. It wasn't practitioners ringing people. It was more sort of a text message, hi, are you okay? And some families and individuals need considerable logistic and financial support, as we've heard in the media. I just wanted to let everyone know about the National COVID Clinical Evidence Task Force. So right from the beginning of April, I think I'll say, there's been a systematic way that multiple panels have looked at the evidence from around the world and made living guidelines, clinical flowcharts, and these are updated weekly. I just wanted that it's worth, if you haven't already, having a look at the mild flowcharts to understand definitions of disease and also the red flags, which is essentially what I showed you before from the health pathway. And then you can also click through to the guidelines. So again, apologies, some of these slides are a bit blurry. I hope you can all see them adequately. So if we look at mild, moderate and severe disease, so we're talking about disease here, not risk, which we'll talk about later. So mild disease is people who are in the community who don't have a complicated course of illness and they have mild upper respiratory tract symptoms, nothing to suggest a sort of pneumonia-like issue sort of developing. So, and moderate illness is in hospital with oxygen and severe, and then there's also a critical definition, but I didn't put that in this slide. There's just a line in between mild and moderate. There's been, in our experience in the towers, for someone with prior normal lung function, an oxygen saturation of less than 94% before or after a brief exertion test was considered referral to hospital. And we can talk a bit more about that later, because when we talk about GPs doing telehealth, clearly you're not actually always going to have oxygen saturation to measure. So it's about trying to assess patients without oxygen saturation. And there are strengths and, well, because you don't need to go and see the patient, but there's obviously oxygen saturation is very important. I also think it's worth, if you haven't already, having a look at the remote assessment tool from the BMJ. That's also, so it's telehealth, and it does recommend that video is better than phone. The main reason being around that you can actually eyeball a person and see if they are deteriorating. So just when we think about monitoring, there's actually no evidence for or against the use of oxygen saturation monitoring, and there's no evidence on the frequency of monitoring. But deterioration can be abrupt and occurs most commonly in the second and third week. And the living guideline at the moment states for people with COVID-19, monitor markers of clinical progression, especially on days 5 to 10 after the onset of symptoms. So I'm going to hand over to Alistair now for a bit of the really complicated slides, Alistair. That was very strategic of me, I think, to offer you to do that. And I'm going to have to advance them, so just say change slides whenever you want me to.
Absolutely. Thank you, Nicole. And thank you all. Well, thank you for the invitation to come and speak. And I guess, tonight is really about updating everyone as to this pilot project and I guess start the conversation about what is likely to be an ongoing process for managing COVID positive people in the community. And so it's, I guess, the key part of the pathway is consolidation of all positive tests. So all notifications of all positive tests that come to DHHS are then fed through into a centralised data capture system, which is REDCap, which then allows for assessment of all of those positive cases to stratify where people are in terms of their risk for really for severe disease. And at this point, so the data will be sent from DHHS to the Royal Melbourne Hospital, who will upload it into REDCap, which can then be viewed by cohealth, and the cohealth team will call each of those people who have had a positive test and stratify them according to a few criteria, which I'll look at in just a moment, into low, medium or high risk, and with the idea that the vast majority of these, probably at least 70% of these, are going to be in the low risk group and won't require any intervention at a hospital level. And the feeling is that that general practice and primary care are well suited to managing this, because they are so many of the issues that we've encountered in managing COVID actually are not related to the medical issues that are associated with it, but rather the social ones. And so GPs are much more aware of the social services and particular circumstances in local areas, as opposed to hospitals who really are pretty hopeless at that. So we can just go to the next slide, Nicole. So there's, I guess, two components to the risk stratification. There's the clinical risk stratification and then a social risk stratification. And people are low risk if they are young, so less than 60. They have no symptoms or really very mild symptoms, and have only well-controlled comorbidities, and are able to be isolated in their own home. And this is crucial. People need to be able to have their own space within their home, and ideally their own bathroom, to adequately isolate in their own homes. If people have more symptoms or are older than 60, or have more significant comorbidities, or those that are not well controlled, they fall within the medium risk stratification, and we can talk a bit more about what that looks like. But those will be admitted to the RMH-led virtual ward. And then obviously those who currently have severe symptoms or can't be adequately managed in the community, then they can be admitted to hospital for their care. And next slide, please, Nicole.
So that is the next one. I think that's, yeah.
So while these initial assessment calls and stratification will be done by cohealth, it's our desire that regular care should continue with people's regular GPs if that's possible. And so certainly, we know that in this sort of complex environment, having some background on a person is really crucial in adequately managing the medical situation and the social problems that go along with that. And so if people have a regular GP, that regular GP will be sent links from the REDCap system to provide ongoing data with a plan to interact with each person who's positive at least twice weekly and up to second daily is the expectation, if that's at all possible. If people don't have regular GPs, then we know that there's been a few GP practices who have put their hands up as being able to take on additional people. And certainly if they are known to cohealth or within cohealth areas, cohealth will take those on with the same expectation of twice weekly or up to second daily phone calls. And I think, this is very much an iterative process. This is the baseline that we've come to, and it's something that will evolve as we further discuss the process and see how it really works under pressure. And I guess the final key component of that of the pathway is making sure that that people have adequate social and as Nicole mentioned, financial supports to enable this care to happen appropriately at home. Next slide, please, Nicole. So this is really just reiterating that in the first week, as we said, people often have mild symptoms or no symptoms. And really from day 5 of symptom onset, we tend to see more severe disease. And I guess it's a really important point that the date of testing is much less important than the date of symptom onset. And it's really, it's remarkable how consistent it is that we see deterioration in that sort of day 5 to 10, and particularly sort of 7 to 9, where people really deteriorate and often deteriorate very quickly. And the idea of contact before that is twofold, I guess. And the first is about making sure that people are picked up early if they have early symptoms, but also to provide a very easy avenue for people to contact the service and get increased assessment if that's going to be appropriate.
I've just got a couple of questions, if you don't mind if I jump in with those.
Absolutely.
Question from Ines. Is any face-to-face or oxygen saturation ever used to determine risk stratification?
Not in the initial stages, no. So there's no intention in that first risk assessment to perform face-to-face assessments. And again, because of that, I guess oxygen saturation monitoring is or testing is not planned.
Yep.
So I think it's worth also saying so that's not part of this model. However, cohealth, for example, has used that in the Towers setting. I guess we're trying to think about something that can be to scale, like there'll be 100 referrals tomorrow coming into the centre. So it's really trying, and we have actually been sending about one person to hospital a day when we've had a lot. We've been waiting for the referral stuff to come through from the Department of Health. There's been a bit of a data issue, but we have actually been, even of 20 or 25 people a day we've been seeing, we've almost always sent one person to hospital.
And just a second question there from Karen. So the 60-year-old age risk, how was that decided, or which reference paper could they review or see for that?
That's a very good question. I don't know the precise.
I do.
There we go. Thanks, Nicole.
Yeah. So prior to Alistair joining the project, we had this discussion backwards and forwards, and that was from Ben Cowie, and it's actually worth reading. There's an MJA piece that Irani from Royal Melbourne and Ben Cowie also put together, and that sort of explains that rationale around 60 and references where it's from. So if you want to, MJA online, I think it's called Management of COVID, we can circulate that at the end of the meeting.
Yep. And just another quick comment from Michael. It's so nice to hear about the beautiful system that appears to be designed to inform rather than Involve GP. How long is it taking from? Sorry, how long is it taking from test positive from the lab to getting to the cohealth team?
So the thing is that the test positives go straight to the department from the lab, and then they're going to come straight to us. So it is possible that sometimes people haven't been notified when we ring them. We're trying to make that loop as short as possible because there has been delays both in the notifications of patients and in the flow of information. And the idea is then to put them as quickly as possible back in with their clinicians, because most people aren't being tested by their GP, they're being tested by a third party, a different service.
And Nicole, I was just going to say, just in relation to the comment about the system sort of informing rather than involving GPs, are you going to go a bit more into the GP's role in managing these patients in a bit more detail that might cover that off?
Yeah, so
as we go through,
it's very much intended that the GP takes on the clinical management of people. So we're saying second daily consults, but if you're concerned about your patient, you can either escalate them into the virtual ward, or you can increase the amount of monitoring. Obviously, most GPs might have to have a practice approach rather than an individual approach to patients because they might not be there every second day. And so you might have to actually book them in with colleagues. But the idea is that general practice really starts to manage mild disease in the community through telehealth.
Sorry, can I just ask a question? I can't, because I'm using my mobile phone, I can't type. Why are we doing this now? Why didn't we do it a few months ago when it started? Why are we doing cohealth now, and why are GPs now taking role by Department of Health? Couldn't we have done that a few months ago? Is that like South Australia? Why are we getting involved after 6 months of COVID? What changed?
What changed? Advocacy changed. People started saying you've got to get it out into general practice. That's what changed. And the numbers made it. So the system was centralised, and you won't get me advocating that was a good idea. But so what changed is advocacy. We were just saying, come on, we've got to get people in care and we've got to get it out into general practice.
Because you were talking about centralized care, and I agree. It was all related, all accent and all focus was on hospitals and Department of Health, and all funds went there. Now, have the government turned the tap off centrally and trying to get work done by GPs? Is there any sort of funding available for GPs? Is there any? Because there was funding and there were lots of nurses and doctors looking after people in a hotel quarantine. There were nurses and doctors looking after in housing commission flats. Now, we are coming to GPs. Why is that just now? Why couldn't we have done that a few months ago? That's what I'm a little bit puzzled about.
Yeah, and look, I think there's a number of reasons, as Nicole's talked about. You know, that there's been a great deal of advocacy for all different types of care to the department, and the public health system within Victoria is different than in other states. It is very much a centralised process. It's not spread as it is in other states, and so. There has been, a slow response in terms of trying to come up with a plan that allows care within the community, which is clearly what is going to make a big difference to managing this.
I mean, I work in Melbourne CBD, and the majority of our patients are actually students, and they have health insurance, but they don't pay for the consults. So, and they don't answer their phone calls. So I'm just worried that that particular young group is not going to do what they're told. You're going to tell them, "I'll see your GP. We found GP for you," but they're not going to listen to us. How are we going to?
We'll talk about. I think it would be interesting if you forward your contact details to the PHN. So international students are absolutely on our radar, and we have been seeing them in the assessment centre, and most of them are young. They have health insurance with varying levels of cover, including cover that excludes COVID care, and they're obviously a particular group that do need a separate funding stream, and we have been advocating for that. So we are very aware that as numbers increase, there are a lot of households, large households of international students with up to 6 members infected, and that they do need care and they will need hospitalisation. But there's a whole system issue here in terms of they don't have ambulance cover, they might have insurance that has lapsed, and then they're also not getting primary care. So I couldn't agree more.
And they're very lonely and isolated, and they don't have anyone to bring food. They don't have anyone to sort of go to the pharmacy. So there is more complex than just...
Yelena, absolutely. The PHN is also aware of that and working with cohealth and Royal Melbourne to continue to advocate for this absolutely vulnerable group that need a lot of services. So we might keep going because we don't have a lot of time. There's a couple of questions that we'll keep a track of, Nicole, and ask you at the end.
So I guess, you know, at that initial assessment, if people are not low risk and don't immediately need hospital care, there's this intermediate level care we're calling medium, or tiers 2 to 3. That provide increasing amounts of support, I guess, with both nursing and medical staff involved in regular monitoring on a largely on a telehealth basis, but certainly in the higher tiers, the possibility of face-to-face at-home review, and in tier 3A and B, we'll be using oximetry for regular monitoring of oxygen saturations at home. And I guess one of the features of the monitoring is a plan to have people doing exercise within their own home. And there's certainly a suggestion that we're likely to see changes in people's exercise tolerance well before they have any resting breathlessness. And so measurement of oxygen saturations at rest and with exercise will be a routine part of that monitoring. There's also a plan to have escalation later down the track. So if people have entered initially into the low risk group, if they need a higher level of monitoring, it can be escalated into that medium group, again, if they don't need admission to hospital. Just go to the next slide, Nicole. So really this is just talking about, again, that escalation from week 1 to week 2 of increasing numbers of visits. And certainly the HITH process, we're looking at twice daily telehealth visits with monitoring, and escalation to home visits if there are any concerns about people in their own homes. There's a very strong component of education and reassurance within the community, and quite a structured process for reviewing people on a daily basis. And there are certainly efforts to automate this to some degree. There are ways that this can be done by people in the community and sent into hospital, and certainly looking at how we can make it most efficient and most reproducible. But the key really is that we have a very structured way of doing it, so that it's, regardless of who's undertaking that review, it's consistent. So just very quickly, so we have the lowest level of care is what we're calling our RMH virtual hospital, which is really for people who have a low level of symptoms but are not considered low risk, either due to age or comorbidity. And telehealth consultations will be performed both by physicians and nursing staff every 2 to 3 days, depending again on the time of their illness, and again, it's really telehealth interviews and escalation if required. The next step up is Tier 3A, which is an extension, I guess, of our current respiratory HARP program. And so this is people who have more symptoms, and particularly respiratory symptoms. I mean, we know while respiratory failure is clearly our, most common feared complication of COVID infection, there are a great many other symptoms that people complain of, and it's remarkable how frequent we see those. But particularly if people are needing extra respiratory support, we have specialist respiratory nurses supported by respiratory physicians who are doing telehealth consultations up to daily, again with oxygen saturation and temperature monitoring, with an aim of identifying deterioration early and being able to escalate that care, as Nicole has mentioned, so that inpatient management can alter the outcome of their illness. The highest level of care is RMH at home or HIS. And again, this is about utilising remote monitoring and frequent telehealth visits, with the possibility of reviewing people in person if needs be. And I think, as Nicole has said, it's really important, what people are saying and what people look like can often be very different things, and so utilising telehealth is really crucial in managing people remotely, because their work of breathing is often as important as anything else that they're saying, in terms of whether they've changed from day to day.
Alistair, just a quick question, and it might be, sorry, more for Nicole, but is the patient's GP informed if they're triaged into one of the medium or high risk categories, or low? Yes. Only? Yeah.
Yeah.
Great.
So the whole idea through this entire, one, the patient has to consent. So the patient might want to go back to their GP and say, I don't want to be monitored by the hospital. That's also fine. And absolutely, I'm not going to say we're going to get it perfect, but absolutely the idea is that we keep GPs informed of where their patients are.
Thanks. We are keeping a track of the other questions as well that we'll hit you with at the end.
Look, I'm very aware there's actually going to be lots of questions. This is just a very quite a complicated flowchart, which really summarises a lot of what we've been talking about. It is worth talking about red cap. So GPs who take on a patient will be asked to do a survey just on entry, and then when they discharge the patient. So there was a thought of doing daily surveys, but it will only be twice. And the red cap, you don't actually have to log into red cap and create a user profile. You literally click on the link. And if your colleague in your practice is then following up the patient, you can forward the link to your colleague, and that will also work. So it's just a link specific to that patient, which might be a good thing to have pasted into their progress notes. This is just a flow that we proposed, especially for cohealth, because we're very aware that some patients will be uncontactable. And just the idea was to call and then leave a text. If you're monitoring patients, to have a second person you can ring, and just explain to the person, I mean, if they're young people, they're not going to be up in the morning, so they might want to opt for an afternoon phone call. And just to be aware that if we can't actually contact you, the department wants to know. It's more from a compliance point of view rather than from a concern point of view. And obviously as clinicians, we might actually have a point of concern.
Nicole, I was just going to say there's been a comment. It might be worth mentioning about how residential aged care facility patients aren't part of this model at the moment. It's a really good point that's been raised about how there's some work to be done in that area.
There's a lot of work to be done in that area, and I think general practice has a really important role to play in that, because GPs are the providers who've been going into nursing homes for many years and often do know their local system well. this is not dealing with patients in aged care, because they have a different care pathway, and the department is involved in an outbreak investigation, and there's a sort of separate process. So if we do receive a notification and it gets identified as aged care, that's where the assessment stops. That is considered, and the department has said that that isn't part of the remit. The other thing is for patients in hotel quarantine, so patients who've chosen to go into hotel quarantine, there is a separate clinical pathway there where there are nurses and doctors. It's managed by the Alfred, but there are many GPs employed in that process. And so again, if someone is in the clinical pathway of in the hotel quarantine, then we're not going to follow them up and put them in with their local GP. I think it's ideal if we let people's GP know, but we're not going to take that further. We're going to have a huge volume of patients to deal with in the next couple of days. So we just wanted to be clear about who we were working with. So I just wanted to move with the role of the GP in the public health response. So as someone who has done a lot of public health in the past, I'm passionate that GPs have a really important role to play in the public health response. And I think this epidemic will teach us that government hadn't really had an embedded approach to population health in general practice, and that was a real weakness in the system when the system got overwhelmed. So we have a role at notification, both to advise patients and give them information about how to protect their family and household members. During follow-up visits, we can reinforce messages and refer to welfare to assist their compliance. We can notify police if not contactable. Some practitioners will see that as a sort of conflict in duty of care. And in this project, we believe that release from isolation will actually become something the GP can do. It was negotiated today with the department. I just want a couple more people to say, yes, that is, which will be great, because some people are kept in isolation for longer than they need to, which is unfortunate. If you've been inside for 10 days and you don't get released for another 3 or 4, I mean, that's quite a burden for people. Just release from isolation. So if the person has been hospitalised or if the person was immunosuppressed, the release from isolation rules are slightly different. If the person is symptomatic and they've spent their whole time being cared for in the community, it's a 10 and 3 rule. And it's, again, 10 days since symptom onset, not test, and 72 hours as symptom-free. And if the answer to that is yes, they can be released from isolation. If they didn't ever have symptoms, they remained asymptomatic. If they're greater than 10 days since they're testing positive, then they can also be released from isolation and be recorded on Red Cap. So they are the current release from isolation, and I think it will be great if GPs actually have that, and clinicians from hospital will be able to do it, because it will mean more timely release from isolation for a whole lot of people. Just to finish off this talk, we want to talk about health pathways. So the PHN has developed a specific health pathway for this project. So it appears 1, 2, 3, 4, 5 down. There's a sort of burgeoning number of health pathways for COVID, but it's the Northwest Melbourne COVID primary management, and I'd encourage you to look at that. These are just some screenshots from that pathway. So it has stuff about the risk categories. It also has important phone numbers, including the public health unit, the welfare support, the virtual ward, and a number for cohealth. Just in the interest of there'll be heaps of questions, what else is happening in the management of mild disease in the community? So we're not the only people involved. Obviously, there's a lot of innovation in the community. The hospital in the home model at Djirriwarra in Melton enrolls everyone with mild disease and monitors with oxygen sats and thermometers. They've got 120 enrolled. They're doing disposable oxygen saturation meters. In other words, they go to the patient and don't come back. And that's GP led by Dr. Karen Aarons, with an excellent team out there. And we will be continuing to, where if there's an existing system, cohealth has an ongoing presence at 5 public housing estates, and we're also doing oxygen saturation monitoring, and I'm very happy to share that if any other organisations plan to do that. And there's also the COVID Care app, which is a trial through Melbourne Uni about symptoms, and I think that also has a role, although not for people who have low health literacy or aren't particularly good with technology. I just wanted to acknowledge many people have been involved in the development of the pilot, and especially Dr. Ben Cowie, who was a lead and has subsequently moved off the response into other VIDS jobs, and also Dr. Karen Linton, who is on the call today. There's a team at Royal Melbourne, including Bridget and Yvette and Meg, and there's a large team at the PHN who have been incredibly supportive through this process. So I thought, in the interests of getting to the questions, we should probably stop there and put it over. Shall I stop sharing my screen? And then I can... yeah, and then we can answer some questions.
Yep. So we've kept a list of the questions that have been going in the chat, and shout out to Karen, who's answered a couple of those. Just wondering though, did anyone have anything that they wanted to raise now before we get to those? Any other questions?
I have a question, if it's possible. It's around the public housing estates and management of people on methadone while also isolating. Just wondering how that might have occurred and what challenges were faced and how they were addressed.
So very big challenges during the lockdown. They were addressed in the housing estates. cohealth was delivering doses to people on bup and methadone. We were also delivering alcohol, and we were also delivering cigarettes. So we were pretty open to what people needed to support them through that period of lockdown. So DHHS is involved from a welfare point of view, and it's not a perfect system. I note a comment recently about difficult experiences with DHHS, but there are ways, and there's AOD workers in our assessment centre to help facilitate that, a sort of Care Connect team. So, for example, if a GP was struggling with some issues around care, they can go back to the assessment centre and ask for support around some of those logistic things.
Nicole, do you just want to stop? You've closed your PowerPoint, but we can still see your screen. Perfect.
There we go.
Good job. So I think Alison's going to run through some of the questions that we've had through the chat.
Yes, so just a couple of questions. One from Jennifer. Do we retest a patient if they have symptoms, if they have been COVID positive, but were given clearance? Yes, so that's the first question there.
Alistair, do you want to answer them, or I don't mind answering?
Look, I mean, I think we know that people will have symptoms for a long time after having COVID, and the difficulty is because it's a PCR test, we don't, unless they've had a negative swab to say that they have cleared it, which we're not recommending routinely. We know that people can shed the virus for weeks and possibly months, and so a positive test is not necessarily going to say that they've had a new infection. We don't know with any certainty whether and when people can become reinfected. There's certainly a number of serology studies from elsewhere in the world that would suggest that the seroconversion rate is not particularly high, and so I think if people have significant symptoms, unless they've had a new significant exposure, re-swabbing them isn't going to change what you do. You would still recommend people continue to isolate if they have symptoms.
Okay, next question. Was there significant risk factors such as lung disease, smoking, etc., found on the young people who developed severe disease or lost lives? What should I look for in young people affected with COVID?
So the young people we're seeing through the assessment centre that we sending to hospital. We sent a 23-year-old today with hemoptysis. We tried to send a 30-year-old who had short chest pain. So you're really looking for sort of, the fact that you've got more pneumonitis or inflammation in the lungs going on, and that's what you're looking for when you're sending people to hospital. There's no really, there is a possibility to do ambulatory assessment in the community if your clinic is up for that. We don't really have ambulatory care services at the moment to do assessments like they do have, for example, in the UK. And that might be something in the future that we have to consider.
Yeah, look, I think comorbidities has been a fairly consistent feature on the whole. I don't have the details of every young person who's had severe disease, but comorbidities have certainly been a strong factor, whether that's multiple or single, but certainly obesity, type 2 diabetes, significant lung disease are certainly features of those younger people on the whole, although not obviously universally.
Great. Another question. People were asking for hydroxychloroquine, and I'm sure now we'll ask for dexamethasone. How should I address this, or how could you address this?
There's a pretty good way to address this. So dexamethasone, the evidence was that it made a difference in moderate and severe disease, but it was actually associated with potentially increased mortality in people with mild disease. So in terms of addressing that with patients, saying that unless you're in hospital, it doesn't work, I think there is a complicated subgroup of people who should be in hospital but refuse hospitalisation, whether they would benefit from dexamethasone. And I would advise that you actually talk to an infectious disease or respiratory specialist prior to doing that.
Yeah, I'd absolutely echo that. It's a discussion I've had in the COVID group at RMH over the last few days, and I think that the universal feeling is that we should be strongly advocating for people to come to hospital if they need hospital care, and working, I guess, with the community in working out who are those people who are going to be at risk of not coming to hospital should they need it, and how do we address that before it becomes an issue. And I guess the GPs and the services in the community are going to know that best. And I think hydroxychloroquine is off the table very much. That there's really there's good evidence that it does nothing, and possible evidence that it causes harm. So no one's getting that. There were clinical trials set up to test that, and they've all been stopped locally. So we certainly wouldn't be recommending that.
Probably a question maybe more for Bianca, this one. So from Mark, who's in a clinic in Casey, we would be happy to help with patients. How can we get involved?
Yeah, so I put a response in the chat there, basically to say that it's planned that this model, if proved successful, would be rolled out beyond this region. So certainly, I guess for patients in Casey to sort of stay tuned, but there is a plan that this does expand, hopefully.
My answer to Mark would be just start advocating really hard, because I think you've got increasing numbers in Casey. Your colour on the purple active cases chart is going up and up, which suggests that the wave of severe in disease and stuff is coming your way. So I would advocate strongly. Ideally, I think this should be wider than just the Northwest Melbourne PHN. So get out there and start talking to people about how management can make a difference, and GPs should be involved.
Great. What is your management of current heroin users in the high rise? Have you been able to continue to manage them in their home? What about people in a similar situation not in high rise?
We had a few issues. The police didn't let anyone deliver heroin to the patients in the high rise. So I mean, look, they were getting them on the long-term bupe. I'm not an AOD specialist, but that's what they were doing for those patients. And just we had in that lockdown situation, which we don't really have anymore. We were getting AOD workers to work closely with them, and we're continuing to do that in the towers.
There's a couple of questions here that I can see is sort of related about what do we know about the sequelae of what patients are left with post-COVID, and is there a sort of a pathway and resources around how to manage people post-acute illness who still have the significant morbidity?
Look, I think it's an area in evolution, and certainly there's many people who are interested in looking at that sort of post-COVID syndrome, which for some people is really very significant and can last weeks on end. People will present with very significant lethargy, persistent exertional breathlessness, and then other various symptoms, including musculoskeletal pains and neurological syndromes. And I think it's outside the scope of this pilot at the moment, but there's a lot of work going on looking at how we might best follow these people up. And certainly within the health pathway, there's a recommendation for referral to services if there are any concerns, and certainly at the RMH we've set up a specific COVID respiratory clinic for follow-up of people who have respiratory symptoms post-COVID, and given that we know that it can cause a myocarditis, that recommendation for undertaking echocardiography and referral to cardiology if there is concern about that. So I think at the moment we don't, certainly within this pathway, we don't have specific plans for managing that and following it up. But on a research basis, we're certainly looking at that and beginning that process to how we can best follow these people up and make sure that those symptoms are being managed.
And this might have been covered before, but we'll make sure we just cover it again. What do the patients do if their regular GP clinic screens out all COVID positive patients and won't give them in-person consults?
We're asking really for the GPs to do telehealth, not in person. So all of this follow-up is telehealth. I think what I was talking about before is at the moment we're kind of saying use telehealth, and then if you're concerned about the patient and you think they need sort of a more urgent oxygen saturation or chest x-ray because you think they have symptoms that might suggest progression, you're sending them to emergency departments. I think in the long run we might have to revisit that at a certain stage, which is what they did in the UK. But that's at the moment we are asking people to do telehealth. If people are deciding to see COVID positive patients, they obviously have to work out a way in person. They have to do that in full PPE, and they have to make sure that they've got the right sort of systems or a back door or a separate room and so forth. So at the moment, this model is really encouraging people to use telehealth. And if you look at what Karen Aarons is doing out in Didjiriwarra, they're actually dropping off the sat meters and doing it that way. So, if people do want to think about more intensive management and general practice, that might be the way to go.
Sorry, I was just waiting, so we just had running out of questions, but we just had one come through. How come ICU admissions are stable around 40 to 50, but daily deaths continue at 15 to 20? Are they all aged care or also mortality in the HARP-HIS group?
Look, I think unfortunately it's largely within aged care. I think this was always a concern for everyone involved, and certainly the experience elsewhere was the mortality rates really escalated really dramatically as people got older. And it's just about the intensity of the inflammatory response. And certainly, people go from being very well and completely asymptomatic to really critically unwell in the space of 24 hours. And so I think, unfortunately, the vast majority are within the aged care system.
And just another question, what is the timeline from the DHHS via cohealth to the patient's GP? What are we expecting?
Okay, so the idea, it's going to be based, on lab notifications. So it will be lab notification to the assessment centre. The assessment centre is going to be there 7 days a week, so there's no delay over the weekend. And then the assessment centre makes that call then. So look, I hope we get closer and closer to seeing people earlier in their disease, because with delays in test turnaround time and delays in notification, we've been seeing people late in disease, which is problematic. If we get a big load coming through this week, we are going to be prioritising on week of illness and age as our first criteria. So we're going to try and go backwards through the older age, always prioritising older people who aren't obviously in aged care.
Someone's asking about disposable pulse oximeters. Can you get them?
No, they're not disposable. So what I should say is, in the Djerriwarrh thing, they were buying the pulse oximeters. They're $40 to $50, but they were considering them disposable, as in they were going one way. They weren't coming back and being cleaned. So you often find you have a household, especially international students, which someone brought up before, where there might be 4 or 5 people in the household. So Djerriwarrh has been giving those pulse oximeters out as a memento of COVID and not bringing them back. So they're not truly disposable. They're just, they're not bringing them back.
If someone remains PCR positive, so greater than 3 weeks post-diagnosis in this case, and has an ongoing cough, do they need to wait for the cough to resolve before, for example, being able to have echoes and other follow-ups for post-viral symptoms?
Probably, unfortunately. I don't think anyone is brave enough to say they are not infectious. And we know, remarkably, one of the highest risk factors for transmission in previous coronavirus epidemics has been doing ECGs. So being in front of someone for an extended period of time puts you at high risk of a significant droplet and probably aerosol exposure. And if someone is still coughing, I don't think there'd be anyone who would be brave enough to say, no, that should be fine. So unfortunately, I think it does mean they'll have to wait.
And just a question around, do healthcare workers need a negative test to return to work?
That's a good question. I don't believe they do. There is guidance around that in DHHS guidance, but I don't think they know. If they meet clinical clearance, then they're able to return to work without a test.
And a question from Hannah: have you found patients or many patients with language barriers?
Yeah, so that's we're using interpreters in the assessment centre. Most of our staff have used interpreters before and are well versed with that. We're finding, I mean, even with the international students, some of which speak reasonable English, I think the complexities of what you're telling them, it's much better to use an interpreter. And certainly on the weekend, that did seem to occupy a bit of the weekend, telling Colombian and other students, international students, that they were COVID positive. So yeah, I think absolutely that's an issue. And I think this is also where, you know, you're often going into families where there's multiple infections, and there'll often be one young person who's doing a lot of the management of their elderly parents or whatever.
So Nicole, this just might be a reinforcement, but the positive patient, do they need a test before coming out of isolation if they're symptom-free?
No, if they're symptom-free for 3 days and 10 days since the onset of symptoms, they haven't been in hospital, including hospital in the home, and they're not immunosuppressed, the answer is no. There's on the DHHS website, there's the whole kind of guide to release from isolation and the public health rules that we can share. You just need a few hours to read it, or an hour maybe, quite long.
If that's a common question that's coming up, we can certainly look to put something, summarise that so it's not taking hours to read and put it in our e-blast.
And it's summarised in the health pathway as well. Yes, to Nade's question, if household members, not family members, it depends if they live together, but if someone's positive, then immediately everyone in their household becomes a close contact. If they remain asymptomatic, they should get a test on day 11. If they become symptomatic, they can get a test, and they can leave isolation to go and get a test. It is one of the reasons to go and get to leave isolation is to go and get a test.
I just recently had a case where after 2 weeks in isolation, the positive person tested positive, but another person tested positive for the first time, and the whole family had to go to isolation again for 2 weeks. So it was 4 weeks. And the person that was tested originally positive and retested positive was released because it was meant to be a dead virus. But the new person positive had to actually stay in isolation with the rest of the family. So it was 4 weeks in isolation, and it was guided by Monash Health, actually.
Yep. So, I mean, Monash, so all of those things is actually through the Department of Health. So that's the authority for that. So yes, if you have a household of 6 people and you've got people consecutively getting COVID, the time starts again for those negative people every time someone in their household gets COVID. So this is a reason to consider hotel quarantine. Although what we're seeing in a lot of young people is just it's ripped through the whole entire household, and 6 out of 6 are positive, with one having sort of worse disease and the rest having recovered.
Do you actually retest these like family clusters? Do they need to be retested? Or not? This was actually some initiative. So the family decided they would actually get retested because they had been waiting for the recall by the department. So they retested and they
So what I advise to people is that people don't just go out and get new tests, that you give them the 1300 651 160 number. If you think they're due for release for isolation, and say you won't get released because you get a negative test, you'll get released because of rules around your symptoms. Because if people keep on getting tested, they're a bit confused. Oh, I'm still positive. Why am I allowed out? But if a family member is asymptomatic, they do get a test on a day 11. Then if the whole family is asymptomatic and tests on day 11, they're fine. But then if someone's positive, clock resets. So
the rule is actually to retest them on day 11.
Only if they're
asymptomatic.
Only if they're asymptomatic. The close contacts get tested on day 11.
All of them?
All of the close contacts. Yeah. And look, I think this is also an important thing to understand. Contact tracing has definitely lagged in Victoria, and it's definitely been a reason why our response why it's got out of control. So, I think this is another part of devolving some of these public health functions and educating general practices so that we can all start working on the team to encourage people to isolate and encourage the right testing of their close contacts.
I thought it was our role from the beginning, and that's why I'm surprised that we are getting involved in this sort of project now, because my practice has been doing that all the time. We have been with the department, we have been in contact with the department, we are following guidelines, and we sort of learn every day. But now we're getting patients from Royal Melbourne Hospital to look after them if they're positive. We had a few of them already.
You're on
Alison,
mute.
I think you're on mute.
Thank you. Sorry, just conscious of time. We've just gone a few minutes over, so it's probably very, very last questions. Just before we go, if there's anything else Nicole, Alistair, Bianca, that you wanted to add before we wrap up today?
I just wanted to thank everyone for the enthusiasm of monitoring patients in the community. I think this is something as GPs we're going to be good at. And for those who don't have services in their area, start jumping up and down and saying you need them. Because I think we've seen again and again when we've run people from the assessment centre that people actually don't have care, and getting a text from the department every couple of days doesn't really count as clinical care.
The only thing that I would add is that we will, a couple of people have asked about the slides. So this is being recorded, and if Nicole and Alistair are happy, we'll share the slides and also the communications that we've put out for general practice and links to the health pathways. That's also got the snapshots of the slides as well around the GP role. And if anyone has any further questions about the modelled, more than welcome to call the PHN and we can point you in the right direction or make sure you've got access to the resources, etc. But there's been lots of comments throughout. I can see here thanking Nicole and Alistair, you for your time and the work that you're putting into this model. Thank you to Karen for answering a few other cohealth related questions. Final closing comments, Al?
I just want to, just for those that maybe joined us a little bit late, just mention that we're in the process of planning to have sessions like this quite regularly, and looking hopefully every fortnight, making sure we have time to cover some clinical content, and also have some question and answer time. So in the evaluation that you'll receive in your inbox probably tonight or first thing tomorrow morning, there is a section that you can complete to say what kinds of topics would you like covered. We certainly have a plan of place, but we'd love to hear from you if there's other things that you would really want covered in relation to COVID and COVID management in primary care. So if you could take a moment to complete that, that'd be really appreciated, and we'll let you know as soon as possible when we've got the next sessions booked and what those topics are going to be. So we have a bit of a series running as well.
Can I ask one question, last question, please?
Yes, sneak it in. Yep.
Because we see a lot of asthma patients in Australia in the primary healthcare setting, and like patients are very anxious that they are, having asthma, they're like known for asthma, and then like getting back to work and risk factors. Like, how is that like reflected? How do I, explain the patient, and like how do I deal? It's a big question, but like I'm just like looking for some expert answers to deal with my patients. Thank you.
Yeah, look, I mean, I think there has been a collective experience that people with asthma, even very mild, usually asymptomatic asthma, if they are to get COVID, have significant flares. Oh, look, I don't want to steal anyone's thunder. There is an update next month, but the key really is if people are on preventers and not taking them, they should be taking them. If they're on preventers, then and have an action plan, then increasing their usual preventer dose to the dose that they take during an exacerbation is sensible. And I guess we're now going to bump up against lots of other reasons for having asthma exacerbations as we come into spring, and so managing people's asthma is really crucial. Smoking cessation is obviously a really key component to that, but taking preventers and increasing preventers is the baseline.
Great. And yes, as mentioned, Madeline's just put in the chat box there that there is going to be an asthma update next month. So in September, we'll be covering some of that COVID information as well. So we'll let you know, and there's a link for more information there. All right, I think we're probably all ready to go. I think you all had a very long day and you need your rest before another big week, I'm sure. So thank you very much, and we'll hope to see you at our future events. Thank you.
Thanks, Alison.
Thanks very much.